There is a moment that never makes it into the published paper. It happens late. The fluorescent lights have that particular hum that only exists after midnight in institutional buildings. A researcher is sitting with a case file open in front of them. The data is clean. The documentation is thorough. The patient history is verified, cross-referenced, signed off by 3 separate physicians. Everything about this case is methodologically sound. And that is the problem, because the result doesn't fit. Not in a small way, not in the way that can be absorbed by a wider confidence interval or a revised p-value. It doesn't fit the way a key doesn't fit when you're standing at the wrong door entirely. The data is not messy. The data is clear. The conclusion it points toward is what's unacceptable. So the researcher does something that will never appear in any methods section. They close the notebook. Not dramatically. Not with any sense of conspiracy. They close it the way you close a door to a room you're not ready to enter. Quietly. With both hands. And they move on to the next project, the next grant cycle, the next paper that will actually get published without ending a career. You have probably never thought about this moment. Science is presented to you as a finished product, a mountain of certainty that grows taller with every passing decade. And in most ways, that picture is accurate. The method works. It is arguably the most powerful tool human beings have ever developed. But a tool is not the same thing as a complete map. And this is where it gets uncomfortable. Not for the skeptics, not for the people who already distrust institutions. It gets uncomfortable for the people who love science, who respect the method, who understand the difference between a controlled trial and an anecdote, who have no patience for magical reasoning. Because the cases you are about to encounter did not come from fringe websites or late-night radio shows. They came from peer-reviewed journals, from university hospitals, from researchers with decades of credentials who documented what they found, published what they could, and then watched as the discipline they devoted their lives to quietly looked the other way. This is not a failure of science. This is a feature of how science operates inside human institutions. The method itself is honest. It follows the data wherever it leads. But the people who use the method have careers. They have funding structures that reward confirmatory results and punish anomalies. A young oncologist who publishes a paper on a spontaneous remission that defies every known mechanism is not celebrated for intellectual courage. She is asked politely whether she checked for diagnostic error. And the neurologist who documents a patient with a destroyed hippocampus suddenly retrieving impossible memories. He doesn't get a rejection letter. He gets something worse, a silence that makes the rejection unnecessary. And so the data accumulates in a place that is hard to name. It is not hidden. It is not classified. It exists in the literature the way certain rooms exist in old houses, present on the blueprints, acknowledged if you ask directly, but never opened during the tour. You are about to open 7 of those rooms. What you will find inside are medical cases, documented, witnessed, published. Cases where the instruments worked fine, the methodology held up, the observations were repeated. And the result was something that no current model of biology, neuroscience, or physics can account for. The researchers who collected these cases did not need courage to believe. They needed courage to not look away. The notebook is open. Imagine you are an oncologist. You have been one for 19 years. You have seen what cancer does. Not in textbooks, but in rooms, in faces, in the particular way a family rearranges itself around a diagnosis. You know the math. You know what stage 4 means. You have learned to deliver the truth without decoration, because decoration is a cruelty of its own. And then a patient comes back. Not sicker. not in the slow decline you mapped out for them in your head during the last appointment. They come back and the imaging is clean, the blood work is normal, the tumor, the one you watched grow across 3 consecutive scans, the one you could measure in centimeters, is gone. Not reduced, not in partial remission. Gone. As if it had never been there at all, except that you are holding the file that proves it was. You run the scans again. You check for lab error. You call pathology and ask them to re-examine the original biopsy, because the alternative, that this actually happened exactly as the data says it happened, means something you were not trained to think about. This is spontaneous remission. And it is not a myth. The medical literature has been documenting it for over a century. More than 3,500 references across 800 journals. Every major cancer type. The numbers are small. Most estimates land somewhere between 1 in 60,000 and 1 in 100,000. Rare enough to be dismissed as statistical noise. But noise does not show up in imaging. Noise does not produce clean biopsies where there were once tumors. Noise does not repeat across different cancer types, different countries, different decades. One case from the literature: a woman admitted to a hospital in Hong Kong in 2006 with end-stage Hodgkin's lymphoma, organs failing, tumors extending from the base of her skull to below her abdomen. Her oncologist did not expect her to survive the night. She fell into a coma. And then, over the following weeks, something happened that her medical team could document but not explain. The tumors began to shrink. Within 5 weeks, the scans showed no detectable cancer in her body. The diagnosis was confirmed. The recovery was confirmed. The mechanism was not. That word, mechanism, is where the conversation stalls every time. Science does not reject that spontaneous remission happens. The documentation is too extensive, the cases too well verified. What science lacks is a why. The immune system is the most common candidate. Perhaps some unknown trigger, hormonal, psychological, immunological, activates a cascade that overwhelms the cancer faster than any chemotherapy protocol could. It is a reasonable hypothesis, but it has a problem. If the immune system is capable of this, if the body contains a switch that can eliminate advanced metastatic cancer in a matter of weeks, then the question changes. It is not how to build better drugs. It is why we haven't found that switch. Because in case after case, the patients who experienced spontaneous remission report something that does not fit neatly into an immunological framework. They report a change, not in their treatment, but in something harder to quantify. A radical shift in psychological state, a moment of surrender or of sudden clarity or of profound emotional release. Others describe similar inflection points. This does not mean that a positive attitude cures cancer, but it means that the cases where remission did occur share a pattern that is psychological as much as physical. And medicine has no model for how a psychological event rewrites cellular biology at the speed these cases demonstrate. So what do you do with this if you are the oncologist standing in that room? You do what the profession allows you to do. You document the outcome. You note it as an anomaly. You move to the next patient because there are 47 more on your list this week, and none of them have time for you to stand here rethinking the relationship between consciousness and tissue. But late at night, in that fluorescent hum, you know what you saw. You know the scans were right. You know the biopsy was right. You know the patient was dying and then was not. And you know that nothing in your training prepared you for the space between those two facts. Picture a woman in a nursing home. She is 87. She has had Alzheimer's for the last 12 years. She has not recognized her daughter in 4 of those years. She has not spoken a coherent sentence in 2. Her neurological scans show what you would expect them to show: severe cortical atrophy, a brain that has been slowly dismantling itself, structure by structure, like a house being taken apart from the inside. The medical staff knows her trajectory. Everyone in that building knows how this ends. And then, on a Tuesday afternoon, she sits up in bed and asks her daughter how the children are doing. By name. She speaks clearly. Her eyes are focused. She remembers the name of the street she grew up on, the song that played at her wedding, the argument she had with her sister in 1974 that they never resolved. She talks for almost 90 minutes. She laughs. She gives instructions about what to do with the house. She tells her daughter she loves her in a voice that has not existed in that room for years. By the next morning, she is gone. If you work in end-of-life care long enough, you hear these stories, not as legends, as shift reports. Nurses describe them with a particular expression. Not shock exactly, but a kind of careful blankness, as if they are reporting something they know they saw, but also know they are not supposed to fully understand. Families describe them as miracles. Physicians, when pressed, describe them as unexpected episodes of lucidity. The medical term, when one finally arrived, was terminal lucidity. The phenomenon was named and systematically studied by Michael Nahm, a German biologist who began collecting cases in the early 2000s. What he found was not a handful of anecdotes. He found a pattern that stretched back centuries. Case reports from the 1800s, descriptions in Greek medical texts. A recurrence so consistent across cultures and time periods that it was difficult to argue it was coincidental or imagined. Nahm identified cases involving patients with tumors that had physically destroyed large portions of the brain. Patients with meningitis. Patients with strokes that had wiped out the regions responsible for language and memory. And in case after case, sometimes hours before death, sometimes days, those patients spoke, remembered, recognized faces they had not recognized in years. If the brain tissue responsible for memory storage and retrieval has been destroyed, confirmed by imaging, confirmed by autopsy, then what was doing the remembering? The standard model of neuroscience is specific about this. Memory is an electrochemical process. It depends on synaptic connections, on neural architecture, on physical structures that can be photographed and measured. When those structures degrade, the function degrades with them. That is not a theory. That is what every scan of every Alzheimer's patient confirms, year after year, in every hospital in the world. Except in the hours before death. When, in a percentage of cases that no one has been able to predict or control, the function returns in full, without the structure that was supposed to produce it. There are hypotheses. There are always hypotheses. Perhaps a final surge of neurochemical activity, a last flood of norepinephrine or cortisol, temporarily reactivates dormant pathways. It is a reasonable guess, but it has a structural problem. The pathways are not dormant. They are gone. In the most striking cases Nahm documented, the tissue that would need to be reactivated no longer existed in any functional form. You cannot restart a circuit that has been physically removed. You cannot reboot software on a hard drive that has been reformatted. A 2009 case report describes an elderly man with severe Alzheimer's who had not communicated in any meaningful way for years. His brain scans showed the degree of atrophy you would expect: severe, progressive, irreversible. In the final days of his life, he recognized his wife. He spoke to her about their past. He used vocabulary and references that required access to memories formed decades earlier, memories stored in tissue that his scans confirmed was no longer intact. He died shortly after. The physicians documented it. They published it. And then they did what the profession required them to do. They noted it as an anomaly and returned to cases where the model still held. If the brain generates consciousness the way an engine generates motion, then what happened in that room should not have been possible. The engine was in pieces. The motion happened anyway. That is the whole problem. Not a philosophical problem, not an abstract one. A clinical problem observed and recorded that no model has claimed. Her daughter never asked for an explanation. She sat with her mother for 90 minutes. That was enough. In 1979, Orlando Sorrell was 10 years old and playing baseball in a park in Virginia. A ball hit him on the left side of his head. He fell. He got up. He did not go to the hospital. He had a headache that lasted a long time, and then it went away, and he assumed that was the end of it. It was not the end of it. Within months, Orlando realized he could do something he had never been able to do before. He could tell you the day of the week for any date you gave him. Any date. Pick one. February 14th, 1987. He would tell you it was a Saturday. He was right. He could also tell you the weather on that day and what he had done. Not just for notable dates, for every single day since the accident. A continuous, unbroken, perfectly indexed record of his life, starting from the moment a baseball struck his temporal lobe. He had never had this ability before. He had no training in calendar mathematics. He had no particular gift for memory. He was, by every measure, an ordinary 10-year-old boy who got hit in the head and woke up with a capacity that no one could explain to him then, and no one has explained to him since. Orlando Sorrell is what researchers call an acquired savant. The condition is rare. The literature contains fewer than 100 documented cases. But what they share is a pattern so consistent it is hard to dismiss. An ordinary person suffers brain damage, a blow to the head, a stroke, a near drowning, and afterward, they can do something extraordinary that they could not do before and never learned to do. Jason Paget was a furniture salesman in Tacoma, Washington. In 2002, he was attacked outside a bar and kicked repeatedly in the head. He sustained a severe concussion. When his vision stabilized, the world looked different to him. Literally. He began seeing geometric structures in everything. Water flowing from a faucet was not a stream. It was a series of discrete mathematical curves. He began drawing what he saw, and what he drew turned out to be accurate representations of complex fractals and geometric forms that typically require years of advanced mathematical training to visualize. Paget had no mathematical background. He had barely passed math in high school. Alonzo Clemens suffered a severe head injury as a toddler. It left him with lasting cognitive impairment. He struggled with basic daily tasks for the rest of his life. But after the injury, he could sculpt. Not in the way a child sculpts. He could look at an animal for a few seconds, on television, in a photograph, walking past a window, and then sculpt a perfect three-dimensional replica from memory. Anatomically precise, proportionally exact. Muscles, tendons, the specific angle of a leg mid-stride. Professional sculptors train for a decade to approach that level of anatomical accuracy. Clemens never trained at all. The standard explanation is that brain damage sometimes removes inhibition. The theory goes like this. The brain normally filters and suppresses enormous amounts of sensory and cognitive data to allow you to function efficiently. Damage to specific regions, often the left anterior temporal lobe, can release that suppression, allowing raw processing power to surface in ways that would normally be blocked. Brain scans of Paget confirmed something along these lines. Regions that are normally dormant had become active after his injury. It is a reasonable framework, but it only answers half the question. It explains why a gate might open. It does not explain what is behind the gate. If Paget's ability to see mathematical structures was always latent in his brain, buried under layers of normal inhibition, then that means every brain is performing complex fractal geometry at a level that most mathematicians cannot reach consciously. If Clemens could sculpt with anatomical precision he never studied, then the information, the spatial data, the proportional relationships, the three-dimensional modeling, was already present, fully formed, waiting to be accessed. Not learned, not acquired, present. That word matters, because learning is something we understand. It has a mechanism. Synapses strengthen through repetition. Neural pathways form through practice. But the acquired savants did not practice. Paget did not study fractals. Clemens did not study anatomy. Searle did not memorize calendars. The abilities appeared, fully operational, after an injury that should have reduced function rather than created it. So the question is not whether the brain can do more than we normally allow it to. The question is where the capacity was before it appeared. What does it mean that a furniture salesman's brain contained a mathematician that had never been consulted? What does it mean that a toddler's brain contained a sculptor that only a head injury could introduce to the world? The standard account requires you to believe that a blow to the head can spontaneously generate mathematical genius. Orlando Sorel still has his ability. He did not ask for it. He cannot explain it. He does not know what it means. He only knows that before the baseball, he was one person. And after it, he was someone who carried every day of his life in perfect sequence inside his head, filed there by a brain that had just been damaged. No one has been able to tell him why. There is a type of case that makes even open-minded researchers pause before putting their name on the paper. Not because the data is weak, because the data is too specific. A boy in Beirut, 3 years old, begins telling his parents about the time he was a mechanic. He gives a name, not his own. He gives a location, a village his family has never visited. He describes the way he died. He does it with the flat, matter-of-fact tone that children use when they are telling you something they consider obvious. He is not performing. He is not seeking attention. He is confused about why the people around him do not already know this. His parents, unsettled, take him to the village he named. He has never been there. When they arrive, he directs them through the streets. He points to a house. He identifies people by name, people who confirm that a man matching the boy's description lived there, worked as a mechanic, and died in the way the boy described. The family of the deceased confirms details the boy could not have accessed through any normal channel. He knows the nickname only close friends used. He knows where a particular object was kept inside the house. He knows about an argument that happened weeks before the death. He is 3. This is not a single anecdote. This is a category of case that has been studied systematically for over 4 decades. And the person who built that body of research was not a mystic or a talk show guest. He was a psychiatrist at the University of Virginia School of Medicine. Ian Stevenson spent 40 years investigating children, typically between the ages of 2 and 7, who claimed to remember previous lives. He did not collect stories. He collected evidence. His methodology was the same you would find in any rigorous field study. Interviews conducted independently with both families, verification of claimed details against public and private records, documentation of birthmarks or physical features that corresponded to wounds on the deceased person, and systematic elimination of alternative explanations, fraud, coaching, coincidence, information leakage through media or family connections. He published over 300 papers. He documented more than 3,000 cases across cultures that have no shared religious framework for reincarnation, including cases in Europe and the United States, where the families had no belief system that would motivate or reward such claims. His work was published by the University Press of Virginia. It was reviewed by colleagues who could find no methodological flaw, only an uncomfortable conclusion. The cases share a structure that repeats with uncomfortable precision. The child begins speaking about the previous life between ages 2 and 3. The statements are specific: names, places, occupations, causes of death. The child often displays emotions consistent with the claimed memories: fear of water if the previous person drowned, attachment to people they have never met in this life, aversion to specific objects or situations connected to the previous death. In a significant number of cases, the child has birthmarks or birth defects that correspond anatomically to wounds, often fatal wounds, documented in the medical or autopsy records of the deceased person Stevenson identified as the claimed previous personality. One case from Stevenson's files: a boy in India born with a pattern of birthmarks on his chest and back. He began describing the life of a man who had been killed by a shotgun blast to the chest. Stevenson obtained the autopsy report. The entry and exit wound locations matched the boy's birthmarks. The boy had no family connection to the deceased. The families lived in different regions. The boy accurately identified the deceased man's relatives, his occupation, and specific events from his life that were verified independently. The usual counter-arguments, coaching, coincidence, overheard information, were the first things Stevenson tested for. His methodology was built around eliminating them. Independent interviews, families separated by hundreds of miles, speaking different dialects, with no detectable social connection. And the birthmarks. Coaching does not produce birthmarks that match autopsy records. What Stevenson never did, and this is what separates his work from nearly everything else in this territory, is claim to know what the data meant. He titled his most important book, 20 Cases Suggestive of Reincarnation. Suggestive, not proof, not confirmation. He presented what was found, how it was verified, and what had been ruled out. The interpretation, he said, was not his department. Jim Tucker, who continued the work at the same university after Stevenson's death, added several hundred more cases using the same protocols. It has been over 50 years since Stevenson published his first major study. The data has not been retracted. The cases have not been debunked. What has happened is quieter and, in some ways, more revealing. The work sits in the university's archive, cited occasionally, engaged with rarely, belonging to no discipline that wants to claim it. A 3-year-old boy in Beirut knew the nickname of a dead mechanic's closest friend. In 2002, the New England Journal of Medicine published a study that should have changed everything. It did not. The study was conducted by Dr. Bruce Moseley, an orthopedic surgeon at the Baylor College of Medicine in Houston. The subject was arthroscopic knee surgery, one of the most commonly performed orthopedic procedures in the United States. Hundreds of thousands of patients underwent it every year for osteoarthritis of the knee. The procedure involved inserting a small camera into the joint, flushing out debris, and shaving damaged cartilage. It was routine. It was expensive. Insurance companies paid for it without question. Patients reported significant improvement afterward. By every institutional measure, it worked. Moseley wanted to find out if it actually did. He designed a randomized, double-blind, placebo-controlled trial, the gold standard of medical research. 180 patients with osteoarthritis of the knee were divided into 3 groups. The first group received the standard arthroscopic procedure, débridement, the removal of damaged tissue. The second group received lavage. The joint was flushed, but no tissue was removed. The third group received nothing. Nothing, that is, except the experience of surgery. The patients in the placebo group were taken to an operating room. They were given anesthesia. The surgeon made 3 small incisions in their knee, the same incisions he would make in a real procedure. He manipulated the knee as if he were performing the operation. He splashed saline water to simulate the sound of the lavage. He spent the same amount of time in the room. He closed the incisions. The patients woke up believing they had undergone arthroscopic surgery. They had not. Nothing had been done inside their knee. The joint was exactly as it had been before they were wheeled into the room. And then, over the following 2 years, something happened that Moseley expected the data to reveal, but that the medical establishment was not prepared to absorb. The patients in the placebo group improved. Not slightly, not in some vague, self-reported, possibly imagined way. They improved at the same rate, to the same degree, on the same functional measures as the patients who had received the real surgery. They walked better. They reported less pain. They returned to activities they had given up. Some of them played basketball. Their knees had not been repaired. Their cartilage had not been shaved. The debris in their joints had not been flushed. The only thing that had changed was their belief about what had happened to them on that operating table. Read that again. The only variable that differed between the real surgery group and the placebo group was information. One group knew, or rather believed, that their knee had been fixed. That belief, operating on a joint that had not been touched, produced the same measurable clinical outcome as a surgical procedure that cost thousands of dollars and carried real medical risk. This was not published in an alternative medicine journal. This was the New England Journal of Medicine, the single most influential medical publication in the world. The methodology was airtight. The results were unambiguous. Moseley himself later said that the most striking finding was not that the placebo worked. It was that the real surgery did not outperform it. The implications of this are not subtle. If a patient's recovery can be fully produced by the expectation of treatment, then what was doing the healing? Not the scalpel, not the lavage, not the debridement. Something in the patient's body received the signal, "You have been repaired," and executed a repair program that achieved what the surgery was supposed to achieve. Without the surgery, the word for this is not miracle, the word is mechanism. A mechanism that medicine uses constantly. Every drug trial has a placebo arm. Every researcher knows the effect is real, but has never explained. The placebo effect is not a nuisance variable to be controlled for. It is evidence that the body has a self-repair capacity that can be activated by belief, expectation, and context. What pathway translates a cognitive state into a cellular event? What system in the body is listening to what the mind believes and then acting on it with enough precision to replicate a surgical outcome? Nobody knows. After Moseley's study was published, the number of arthroscopic surgeries for osteoarthritis did decline, eventually over more than a decade, and only after additional studies confirmed the same finding. But the deeper question the study raised, how expectation produces tissue-level change, was never integrated into how medicine trains its doctors or designs its treatments. The finding was absorbed as a footnote about one specific surgery. The principle behind it was left where it was. The incisions healed, the knee improved. The surgeon had done nothing. There is a kind of pain that should not exist. A soldier loses his left arm in combat. The arm is gone, confirmed by surgery, confirmed by the empty sleeve, confirmed by every piece of visual and tactile evidence available. And yet, weeks later, he feels it. Not a memory of the arm, not a psychological metaphor. He feels the arm itself, the fingers curled into a fist so tight it burns, the nails digging into a palm that is not there, a cramping so specific he can describe which tendon is involved. He feels this every day. Some days it is worse than the injury that took the arm in the first place. This is phantom limb pain. It affects the majority of amputees, and for decades, it was treated as a psychiatric curiosity, the brain mourning a limb it had lost, producing ghost signals as a kind of neurological grief. A sad side effect. An echo. V.S. Ramachandran did not think it was an echo. He thought it was a window. Ramachandran, a neuroscientist at the University of California, San Diego, proposed something that sounded absurd the first time anyone heard it. He placed a mirror in a box. The patient put their intact arm on one side and their stump on the other. When they looked into the mirror, they saw what appeared to be two complete arms. The reflection of the intact arm occupied the space where the missing arm should have been. And then Ramachandran asked the patient to move both arms simultaneously. The pain stopped. Not in every case. Not permanently, not always on the first attempt. But in a significant number of patients, the visual feedback, the sight of an arm moving freely where there had been only absence and agony, was enough to release the phantom fist, unclench the fingers that did not exist, and dissolve pain that no painkiller had been able to touch. Think about what this means. The pain was real. It was not imagined. It registered on every neurological measure available. But it was not being generated by the arm, because there was no arm. It was being generated by the brain's model of the arm, an internal representation so detailed, so persistent, that it continued to produce sensation in a limb that had been physically removed. And that model could be edited, not with surgery, not with drugs, with a mirror. Close your eyes and feel your left hand. What you are feeling is not your hand. It is your brain's best guess about your hand. Ramachandran's mirror proved that when the guess changes, the experience changes with it. Pain that had no physical source could be eliminated by visual information that had no physical basis. A reflection cured what pharmacology could not. If the brain maintains a model that can generate real pain in absent limbs, and if that model can be rewritten by something as simple as a visual illusion, then how much of what you feel in your intact body is also a product of the model rather than the tissue? Ramachandran himself called the implications disturbing, and he was not a man who used that word casually. The mirror is still used in clinics today. It works. And nobody has been able to fully explain why a reflection can do what morphine cannot. In 1991, a woman named Pam Reynolds was wheeled into an operating room at the Barrow Neurological Institute in Phoenix, Arizona, for a procedure called a standstill operation. She had a giant basilar artery aneurysm, a ballooning blood vessel deep in her brain that would kill her if it ruptured. The surgery required something extreme. Her body temperature was lowered to 60 degrees. Her heart was stopped. The blood was drained from her brain. Her eyes were taped shut. Molded speakers were inserted into her ears, emitting continuous clicking sounds at a known frequency, a standard method for monitoring brainstem function. By every clinical measure used to define it, Pam Reynolds was not conscious. By several of those measures, she was not alive. The surgery lasted several hours. It was successful. She survived. And then she told her doctors what she had seen. She described the Midas Rex bone saw used to open her skull, a tool she had never seen before, and that was brought into the room after she was already under anesthesia. She described its shape accurately. She described the interchangeable blades and the case they were stored in. She described a conversation between her surgeon and a female colleague about the size of her femoral arteries. She reported the specific song that was playing in the operating room at a particular point during the surgery. She described these details from a vantage point above her own body. Her ears were blocked. Her eyes were taped. Her brain showed no electrical activity during the period she later described. The surgical team confirmed her observations. The details were accurate. The conversation happened. The saw looked the way she described it. The song was playing. Michael Sabom, a cardiologist and researcher who investigated the case, documented everything. The anesthesia records, the brainstem monitoring data, the surgical notes. He published his findings. The case became one of the most scrutinized accounts of a near-death experience in the medical literature. Not because it was the most dramatic, but because the clinical controls were extraordinary. Reynolds was not simply unconscious. She was in a state where, according to everything neuroscience knows about how perception works, perception should have been impossible. The explanations that have been offered are the usual ones. Residual brain activity too faint to be detected by the monitors. Reconstruction of details after the fact, assembled unconsciously from ambient information. Lucky guesses. None of them accounts for the specificity of what Reynolds reported. The saw, the blades, the case, the conversation, the song, under conditions where sensory input was verifiably blocked. What this case does is place a single, clean data point on the table that the current model of consciousness cannot explain without bending its own rules. Pam Reynolds died in 2010 of heart failure. She spent the last 19 years of her life knowing something that no theory could contain. That on a day in 1991, in an operating room in Phoenix, she saw things she could not have seen, heard things she could not have heard, and remembered them with a clarity that the people in the room confirmed. The monitors said she was not there. She was. You have now seen 7 cases, 7 entries in a file that no one asked you to open and no one will ask you to close. A woman whose cancer vanished without treatment. A grandmother who remembered everything with a brain that could remember nothing. A boy who was hit by a baseball and woke up carrying every day of his life in perfect sequence. A 3-year-old who knew the nickname of a dead man he had never met. A knee that healed from a surgery that never happened. A soldier whose phantom pain was cured by a reflection. A woman who saw her own operation from above with taped eyes and a silent brain. These cases do not share a discipline. They do not share a mechanism. They do not point in the same theoretical direction. What they share is simpler and more uncomfortable than any of that. They are real. They are documented. And they do not fit. There is a version of science that knows what to do with this. It is not the version that gets funded or taught in the first year of medical school, but it exists. It is the version that remembers what the method was designed to do in the first place. Not to confirm what we already believe, but to follow what we observe, even when what we observe leads somewhere the institution is not ready to go. The data arrives first. The framework resists. The framework eventually breaks. And then everyone acts as though the new understanding was obvious all along. The cases in this video are at the first stage of that pattern. The data has arrived. What comes next is not something any single video or any single researcher can determine. This happened. Now what? There is a researcher somewhere, maybe not the same one from the opening of this video, maybe a different one, younger, earlier in their career, sitting with a case file that does not fit. The fluorescent lights are humming. The result is clear. The data is clean. And this time, they are not closing the notebook. They are reading it again. They are calling a colleague. They are asking a question they were not trained to ask.